In this video, we will be covering respiratory muscles. Part 1. Introduction to respiratory muscles. Respiratory muscles function as a complex pump system. Effective breathing requires coordinated contraction of multiple muscles. Diaphragm is the most important inspiratory muscle. When this system weakens or fails, it directly results in respiratory failure. Structural and functional properties of respiratory muscle overview. Respiratory muscles are skeletal muscles and share many characteristics with limb muscles. However, they differ in key ways. Instead of producing movement against inertial loads, they overcome resistive and elastic loads. They contract rhythmically and continuously, making them essential for survival. To sustain continuous activity, respiratory muscles are highly adapted. They demonstrate high fatigue resistance, increased oxidative capacity, dense capillary supply, and greater blood flow compared to limb muscles. Structural properties of respiratory muscles. Structural properties of respiratory muscles depend on three main factors: the type of muscle fibers present, their morphological characteristics, and the organization of motor units. First factor, fiber types. Classification of muscle fibers. Muscle fibers are classified based on myosin ATPase activity and their response to pH conditions. There are mainly four types: type 1, type 2A, type 2B, and type 2X fibers. Type 1 fibers. Type 1 fibers are slow twitch fibers with high endurance capacity. They are rich in oxidative enzymes and highly resistant to fatigue, making them ideal for sustained respiratory activity. Type 2 fibers. Type 2 fibers are fast twitch fibers that generate force rapidly. Type 2A are fatigue resistant relatively, while type 2B fibers are more glycolytic and fatigue quickly, and type 2X fibers show intermediate characteristics. Functional differences between the two fibers. Functionally, type 1 fibers are optimized for endurance, while type 2 fibers are designed for high force generation. Type 2A fibers combine endurance, whereas type 2B fibers generate highest force but fatigue rapidly. Fiber distribution in respiratory muscles. Respiratory muscle contains a mixture of fiber types. Diaphragm has predominantly type 1 fibers, around 55% supporting endurance. Other respiratory muscles also have high proportion of oxidative fibers, enabling sustained activity. Next factor, morphological organization. Basic organization of muscle fibers. Structurally, respiratory muscles are organized into bundles arranged in parallel. Each muscle fiber contains myofibril, which in turn are composed of sarcomeres. Sarcomeres are fundamental contractile unit consisting of myosin and actin filaments. Force generation mechanism. The force generated by a muscle depends on number of myofibrils arranged in parallel. In contrast, displacement and shortening velocity depend on number of sarcomeres arranged in series. Mitochondrial density. Respiratory muscles, especially diaphragm, have higher mitochondrial density compared to limb muscle. Approximately 80% of diaphragm fibers are oxidative, allowing greater oxygen utilization. Capillary density and blood flow. Respiratory muscles must receive significantly higher blood flow than limb muscle due to a greater capillary density, approximately twice that of limb muscles. This allows diaphragm to sustain continuous rhythmic contractions effectively. Functional role of fiber types. Type 1 and Type 2A fibers support resting ventilation. During increased demand such as exercise, Type 2 fibers are recruited. Type 2X fibers generate high power outputs required for actions like coughing and sneezing. Functional implication. These structural adaptations enable respiratory muscle to sustain continuous rhythmic contraction, maintain high endurance, and efficiently utilize oxygen. Coming to the third factor in structural properties of respiratory muscle, motor unit organization. Muscle fibers are organized into motor units, each consisting of a motor neuron and the muscle fibers it innervates. All fibers within motor units are of same type and are widely distributed across the diaphragm. The innervation ratio in diaphragm is approximately 2500 muscle fibers per motor neuron in humans. Smaller motor units allow finer control, while larger units generate greater force. Types of motor units. There are 4 types of motor units. Type S are slow and fatigue resistant. Type FR are fast but still resistant to fatigue. Type F intermediate show intermediate fatigue, while type FF are fast and highly fatigable. Force generation and recruitment pattern of motor units. Fast motor units are larger and generate higher force around 110 millinewtons. In contrast, slow motor units are smaller and generate lower force, typically between 30 to 60 millinewtons. Motor unit recruitment follows size principle. Smaller fatigue resistant units are activated first, followed by larger units. So we have covered the structural properties of respiratory muscle. Now in next part of the lecture, we will cover the functional properties of respiratory muscle. First, functional assessment of respiratory muscles. Respiratory muscle strength is commonly assessed using maximal static pressures at mouth, MIP, MEP. It can also be evaluated more precisely using esophageal, gastric, and transdiaphragmatic pressures. Additional assessment methods. In patients who cannot cooperate, non-volitional methods such as electrical or magnetic stimulation are used. Muscle endurance is typically assessed using repeated submaximal efforts until fatigue. Advanced evaluation techniques. Advanced techniques include ultrasound for assessing contractility, electromyography to measure motor output, electroencephalography to evaluate cortical involvement, and transcranial magnetic stimulation to assess neural pathways. In the last part of lecture, we will be covering functional properties of respiratory muscles. Functional properties of respiratory muscles are described using several relationships including force-length relationship, pitch characteristics over time, force frequency, and force velocity relationships. First, force-length relationship. Force-length relationship. The diaphragm follows the force length relationship where maximal tension is generated at the optimal length. The relationship is altered in pathological conditions. Length changes during breathing. The diaphragm undergoes significant length changes of around 30 to 40% vital capacity, whereas other respiratory muscles show smaller changes. At functional residual capacity, diaphragm operates close to its optimal length for force generation. Length tension curve. The length tension curve shifts in emphysema. In chronic hyperinflation, adaptation allows optimal filament to overlap to occur at shorter muscle lengths, partially restoring function. Effect of hyperinflation. In hyperinflation, the diaphragm becomes shortened, reducing its ability to generate force and placing it at a mechanical disadvantage. Effect of hyperinflation on muscle length. With hyperinflation, the parasternal muscles move closer to their optimal length. The scalene and sternocleidomastoid tend to function on the ascending limb of length tension curve. However, diaphragm retains a greater mechanical advantage compared to other inspiratory muscles. Chronic adaptation. With chronic hyperinflation, the diaphragm adapts by reducing number of sarcomeres in series. This partially restores force generation despite persistent shortening. Additional mechanism for weakness. Reduced force generation is also due to decreased filament overlap, impaired calcium activation, and partly due to T-tubular dysfunction. Clinical implication of force length relationship. Inotropic agents have greater effect on shortened diaphragm, making this concept clinically relevant in patients with severe hyperinflation. Force frequency relationship. Force frequency relationship. The muscle force increases with stimulation frequency. This increase is steeper in slow muscles due to longer relaxation time. Diaphragm shows intermediate characteristics, and at frequency between 10 to 30 Hz, fused tetanic contractions occur. Effect of acute shortening. Acute muscle shortening causes a downward shift in force frequency curve. This reduces maximal force, but importantly, submaximal force generation is disproportionately affected. Force frequency curve. At reduced muscle strengths, such as 70% of optimal, there is a marked decline in force generation, especially at lower stimulation frequencies. This has important implications in hyperinflated states such as COPD. Force velocity relationship. Force velocity relationship shows that contraction velocity decreases as load increases. This relationship is determined by myosin ATPase activity. The diaphragm exhibits intermediate characteristic between slow and fast skeletal muscle fibers. Power generation. Power output of respiratory muscle is a product of force and velocity. Peak power output occurs at approximately 30% of maximal force and 30% of maximal velocity. Several functional relationships including frequency force, frequency velocity and frequency power relationship all depend on frequency of stimulation and determine overall muscle performance. Fatigue effects. Fatigue significantly alters all functional properties of respiratory muscles. However, diaphragm is more resistant to fatigue and recovers up to 10 times faster than limb muscles performing similar tasks. In summary, respiratory muscles are specialized skeletal muscles functioning as a continuous pump. The diaphragm is predominantly composed of type 1 fibers providing endurance, while type 2 fibers are recruited during increased demand of force generation. Key adaptations includes increased oxidative capacity, increased mitochondria, increased capillary density, and increased blood flow. Motor units follow size principle, allowing efficient and graded recruitment. Functionally, performance depends on length tension, force frequency, and force velocity relationships, with peak power generated at around 30% of maximal force and velocity. In conditions like hyperinflation, the diaphragm shortening reduces force generation. Ultimately, respiratory failure occurs when load exceeds muscle capacity. Diaphragm, however, is highly fatigue resistant and recovers faster than limb muscles.